Hello, and welcome to your first lecture, not the first, but the lecture on sepsis, MODS, SIRS, and DIC. Today we're going to be talking about really complex physiologic events that involve widespread damage to the endothelial layer of the vessels and a systemic inflammatory response. And to understand these disorders, to understand the pathophysiology today, we are really going to need to spend a little bit of time and understand the basic inflammatory response and the role of the endothelium. So normally when we talk about inflammation, we talk about a localized immunologic response. That means that when tissues are injured or there's an infection, there's a foreign object that enters the body, there's trauma, there's an allergen, excess heat or excess cold, the body enters into an inflammatory response. It is important that you remember, that you note, inflammation can occur without infection. So you can have inflammation without infection, but infection causes inflammation. Okay, so the white blood cells, we know that they are responsible, and in a couple weeks we're going to talk really a very thorough lecture about the immune response. Today we're talking about the inflammatory response, but we'll have the whole picture in a couple weeks. So there's white blood cells, and we all know that white blood cells fight infection. We know that the white blood cells are the ones that are responsible for phagocytosis. So these cells, the basophils, or you'll also hear them referred to as the mast cells, and the monocytes, like to locate themselves near the surface in capillary-rich areas, and they're ready and poised to initiate the inflammatory response. So they're near the surface, and they like to cluster themselves near portals of entry. So in the nose and pharynx area, in the throat, in the groin, areas where there is portals of entry, we have lots and lots of these basophils or mast cells and these monocytes. And so what happens when we're going to have an inflammatory response? So we get an abrasion, a cut, a burn, even an infection, meaning some sort of a pathogen enters the body. And then we have these mast cells, monocytes, that are hiding under the skin. And so as soon as this invader gets in there, the body recognizes it as being foreign. And once it recognizes it as not being self, the mast cells or the basophils are going to release histamine. What happens when it releases histamine? Histamine is going to cause the vessels, remember they're located in capillary-rich areas. Histamine is going to ask those capillaries to vasodilate, to get nice and big, to expand their volume. And what is that going to do? It is now going to allow all the good cells, all the good white blood cells, all the B cells, all the T cells, they're going to rush in there, and they're going to take care of this invader. Infection, a pathogen, a stir, an abrasion, whatever it's going to be. So that's step one of the inflammatory response. So the basophils or the mast cells produce histamine. Histamine causes vasodilation. All the good cells rush in. Then we also have these monocytes, which are also white blood cells. And monocytes are also hiding in those areas very close to the surface, on alert, the guard dogs for infection, for intruders. And when they are stimulated, the monocytes will release cytokines. And we say that cytokines are the cell mediators of the inflammatory response. I'm going to say something right now that's not going to make sense until we do the immune response. But you'll make a note in here so that you'll be able to close the loop on this concept. So put this in your notes right now. You're going to say that cytokines come from activated T helper cells. And after the activated T helper cell, the monocytes become macrophages. It doesn't make sense right now. I don't need it to make sense right now, but it will make sense when we do the immune system. Okay, so the monocytes, so we had the basophils, or the mast cells, making the histamine. They cause vasodilation. All the good things rushed in. Now we have the monocytes, and they're going to release cytokines. After they release cytokines, they're going to engage in some phagocytic activity and try and chomp down the invader. And these cytokines are what's going to start the entire inflammatory response. So we had the vasodilation with the influx of goods, with good things. And maybe that was enough to arrest whatever the problem is. Maybe there was just a small little splinter that came in and no big deal. But as the inflammatory response continues, we are going to see vasodilation as histamine continues to be produced because the invader is still present. As the histamine is released, we had the vasodilation initially, but then we are changing the permeability of the vessels. By changing the permeability, what I'm saying is normally a capillary does not let white blood cells and plasma protein leave the vascular space. But when I have inflammation, I need white blood cells and I need plasma protein. So let's imagine this knee in this picture. It might be a finger. I'm not sure what it is. That was an interruption. I'm sorry. So as the permeability changes, we have little windows in the capillaries that are kind of opening up and allowing white blood cells, good cells, to fight infection, and allowing plasma proteins to leak into the surrounding tissues. Because let's pretend that cut on that finger, knee, whatever it is, let's pretend that there is an invader. So the invader is not just in the capillary space. The invader is in the tissues. So what we have is there's an invasion and there was damage to a capillary in that area. So we had the vasodilation, and then as the histamine keeps being produced, the permeability of the vessels is changed. Then the fluid that opens little windows in the capillaries and allows fluid with lots of white blood cells and plasma proteins to rush into the area to help to get under control the infection or the pathogen or the invader, whatever it will be. They are doing their job. The cytokines are one of the things that they're going to do in the body is they're going to create a sympathetic nervous response, and that sympathetic nervous response is going to increase the number of catecholamines. That way we can keep having vasodilation. We can have tachycardia, and the tachycardia that we'll have is because to allow blood to rush to the area. I'm going to advance the slide. So it's going to allow blood to rush to the area, and when the blood rushes to the area, we are going to have some redness. The redness is great because we are going to have all those fluids. That means lots of blood is there, and when lots of blood is there, it's doing its job and it's getting rid of infection. We have an increase in temperature. We have an increase in fibrinogen, so we are able to make a clot if there's a problem. So I would say we have an increase in histamine, causes vasodilation, changes the permeability, all the good cells rush there. That's what the histamine is doing. In addition to histamine, making it available for cells to rush there and changing the permeability, we have cytokines orchestrating. They're calling, come on everybody, there's an infection. Everybody rush down here. Everybody take care of this problem. So I'm going to increase my sympathetic nervous response. So catecholamines are there. I have an increase in metabolism. I have an increase in clotting. I have an increase in temperature. And there we see, because of the vasodilation, we see that's allowed to happen there, we see swelling or redness, and it's manifested as tachycardia. So when we talk about the signs and symptoms of inflammation, locally we have rubor, erythema, redness, whatever word you want to call it. We have heat, temperature. We have swelling because of all of the plasma proteins and all the good cells in the blood that has rushed to that area. Naturally, we should have pain, and occasionally we will have function. Systemically, we would have an increase in the white blood cells because the cytokines are saying, come on, white blood cells, we need you down here to do the job. You probably might have fever, malaise, maybe even some anorexia. So let's review the cytokines. The cytokines are cell mediators of inflammation. They are released from monocytes so that you can say that when monocytes are high, inflammation is going to be high because they're the ones that are the mediators. They are the messengers for the rest of the body. Come on, body, let's get down here. Let's do our job. So temperature goes up, metabolism goes up, catecholamines are released, heart rate is up, vasodilation is promoted. Another important part about the catecholamines is that they play an important part because they trigger the liver to increase fibrinogen. And you remember that fibrinogen is part of the clotting cascade. And then we have all those other serum proteins like C-reactive protein that will help in a normal situation. I'm gonna stop there. I'm not gonna say that. Okay, so that's enough on catecholamines. Let's talk now about the process of how it actually works. We're going to talk 1 second about the parts of the white blood cell, different varieties of it. We have the mast cells or the basophils, which we've talked about the histamine being released. We have the monocytes, which are the cell mediators of inflammation. And we also have eosinophils. Eosinophils are leukotrienes, produce mucus, leukotrienes. So all of these are important when we are talking about the inflammatory response, and we'll talk about them in depth in a couple weeks when we do the immune response. Next, we have the neutrophil. Neutrophils release nitric oxide and allows them to stick to the endothelial wall. Okay, why is that important? Well, under normal circumstances, it is very important that we heal an area that's been damaged. So let's picture that abrasion on that body part that we saw on the initial screen. And we had the vasodilation, we had the cytokines calling everybody, we had the catecholamines that were released from the cytokines that were increasing the amount of platelets or fibrinogen that was blood clots that could be made. So normally we'd have a neutrophil that would come and it would stick to the endothelial wall in that area. And it kind of damages the wall a little bit when it's there, but it's important. So the neutrophil sticks there. And when the neutrophil sticks there, it begins to line the endothelial bed. And we call that margination. When the neutrophil, or the sticky neutrophil as they call it, sticks to the wall, endothelial wall, then we will have all these platelets that are rushing past, and platelets will actually clump on top of that neutrophil, and we have kind of neutrophil entrapment, okay? But that's okay if the inflammatory response that we're talking about is localized. The problem is, the diseases that we're going to talk about will be talking about when that inflammatory response is no longer localized. Normally, this sticky neutrophil process where the white blood cells stick and the platelets cover that and make kind of like a little blood clot right there, that is self-limiting. The whole thing, because of pro-inflammatory cytokines that are, their job is like a C-reactive protein. Their job is to stop inflammation, to stop that inflammatory response. So normally it's very self-limiting, and it happens right on the knee, sprained ankle, in your bladder if you have a UTI, in your lung if you have a pneumonia, but it's contained to that area. Now we're going to talk about SIRS, Systemic Inflammatory Response Syndrome. SIRS happens when cytokines are no longer localized and they circulate in the bloodstream remote or far away from where the actual problem is. So we said that normally an inflammatory response is self-contained in a local area. We have all those good things, all those inflammatory mechanisms to heal us up. And then normally the process just shuts down because we've taken care of the problem. But if for some reason the inflammation or the inflammatory response becomes uncontrolled and generalized, it can kind of, like there's a lot of really well-developed checks and balances that start the inflammatory response and stop the inflammatory response. So if for some reason that inflammation escapes those checks and balances, it will result in an unregulated inflammatory response, and there will be widespread involvement of all the endothelial cells, and it is generalized activation of inflammation and the coagulation cascade as part of that inflammation. So that's what it is when we're talking about SIRS. We're really talking about an inflammatory response that has gone crazy and is systemic and massive all over the body. So let's think about what's going to happen. Now we're talking about inflammation that is happening everywhere. The problem started with a urinary tract infection, or started with pneumonia, very, very common causes of problems. And we'll get to definitions in a minute. Let's say it starts in the bladder. Or no, you know what, I'm going to say, because we're talking about SIRS, let's say it starts as a crush injury. It starts as a crush injury, some sort of a crushing leg injury to the leg, and we had a localized response. All of a sudden, the immune system goes wild, and it is no longer self-contained. It is no longer just at the leg. Inflammation is happening everywhere. It's happening in the leg. It's happening in the arm. It's happening in the gut. It's happening in the lungs. It's happening every single spot in the body. So let's think about that. So we have histamine being released, but those mast cells or the basophils are releasing the histamine. So we have vasodilation. Not vasodilation in the leg that had the crush injury, vasodilation in the entire body. And instead of just changing the permeability of the vessels in the leg, we're changing the permeability of the vessels everywhere. So when we change the permeability of the vessels everywhere, we start leaking. Yes, that's good, but we're leaking out all our white blood cells and plasma proteins, and our plasma protein is albumin. And when we start to leak albumin out of our vascular space into the interstitial space, you know from your fluid and electrolyte lecture that albumin is responsible to hold fluid inside the vascular space. So let's picture now these massive inflammatory response, massive vasodilation. So when I say massive vasodilation, you should be thinking, oh my goodness, low blood pressure. And then fluid is leaking in addition to that. Fluid is leaking out of the vascular space into the interstitial space. And now I have a decrease in circulating volume. That means fluid has leaked out and it's in the third space. It's not in my vascular space. And if it's not in my vascular space, I have decreased cardiac output. And you know, when I say decreased cardiac output, you should be saying to yourself, there will be poor tissue perfusion. In addition to the histamine exerting its effects massively all over the body, we will have the cytokines calling for all kinds of responses. And what will it do? It will want to increase the heart rate, okay? It's going to increase vasodilation. It's going to increase clotting. And what else does it do? When the cytokines get activated, when the cytokines are calling for a response, those sticky neutrophils start sticking on the blood vessels or the endothelium. And on top of those sticky white blood cells, neutrophils, we have platelets sticking on there. And when we had a localized response in my crush injury in the leg, it was okay. I had some blood clots in there and the blood was moving around the injured area. But if I have a massive inflammatory response, you can imagine these neutrophils covered with platelets are sticking all over on all kinds of different vessels, and they're causing roadblocks. That means that the blood can't get down. That means the blood is coming out of the aorta and it's trying to get down to the kidney, to the renal artery, and it can't get to the renal artery. So it has to go another place, and there's blood clots all over. So they call that maldistribution of circulating blood. In other words, we're trying to circulate the blood, but there's all these millions and millions of little blood clots all over the place for no reason, creating roadblocks. Just like if we have, a bad snowstorm or a flood situation, a hurricane, rivers are high, you can't get down the roads, and you might not be able to get to where it is that you're supposed to be going. So because of massive vasodilation and the leaking of protein-rich fluid into the interstitial space, as well as the pavementing of the endothelium or those blood clots causing roadblocks all the way around, we will have decreased tissue perfusion, decreased cardiac output, and resulting in decreased tissue perfusion. And when we have decreased tissue perfusion, you know that you will have an increase in the sympathetic nervous response, you will have an increase in the renin-angiotensin-aldosterone system, and you will have an increase in ADH. And unlike those compensatory mechanisms in heart failure, which kind of caused additional problems, these are necessary to try and maintain perfusion to the primary organs. One more thing we need to talk about. In addition to the massive vasodilation and the increased capillary permeability, the maldistribution of blood related to those blood clots, the pavementing of the vessels. The body also, when we're having a SIRS, a systemic inflammatory response, enters into a hypermetabolic state. What does that mean? Well, the liver is responsible when we have increased catecholamines. We know one of the things that happens is we have an increase in the release of sugar from the liver. And we need that. We used the example before that, I need a sympathetic response, so I need a lot of sugar because I'm going to have to run a mile away from a bear that's chasing me. So I need lots and lots of energy. So as we have this massive inflammatory response, the liver begins to convert glycogen to glucose. And that's good because it increases our sugar stores. But the glycogen will soon become depleted because it's not just a localized response. Remember, everywhere it's massive, it's huge. So after we deplete our glycogen stores, we start to burn fatty acids, amino acids, for energy. And when we're burning those amino acids, that is depleting our protein stores. And we need protein to make which is the albumin, to hold fluid inside the vessels. So you can see that we had fluid leaking out because there was changes in permeability. As time goes on, the liver will use up its glycogen stores, and then it will burn amino acids. And as we burn amino acids, we're able to make less albumin, and that's even more fluid leaking into the interstitial space, resulting in decreased circulating volume and a decreased cardiac output and decreased tissue perfusion. And so we're burning these acids or fatty acids for fuel. And you should say, well, when we're burning fatty acids for fuel, yikes, that means that we're making an acidic environment because we are releasing ketones as a result of fatty acid metabolism. So then let's think about it even further. So we have that hypermetabolic state where we end up burning fatty acids. And we have also, I told you that we had increase in catecholamines because of the cytokines. Well, when we have an increase in cytokines, you should know that we have an increase in glucose production because that's what the liver is doing. But we also have an increase in cortisol levels. And so cortisol makes an insulin resistance. So initially we will have an increase in glucose and insulin resistance. But then, with all the extra cortisol on board, it's fight or flight, this is a major problem. With all the extra cortisol on board, we have muscle wasting. So we have all the catabolic effects of the increase in cortisol. And so, eventually, despite all the efforts of the liver, it will fail to be able to make sugar, and we will have hypoglycemia. So in the beginning, you will see hyperglycemia as a result of the increase in cortisol and the increase in insulin resistance. But as the liver begins to fail, because it's burned all its glycogen, it's burned fatty acids, so eventually we will end up with a hypoglycemia. Eventually the liver will begin to fail and it will not be able to synthesize protein, and we will have a decrease in that onconic pressure, and the fluid will leak out of the vascular space into the interstitial space. One last word before we leave this slide. There are three main things that you need to know about SIRS. Vasodilation comes from the mast cells or the basophils. The vasodilation results in increased capillary permeability. You will have cytokines released from the monocytes. The cytokines will cause the sticky neutrophil to be covered by the platelets, and it will cause maldistribution of blood, an inability of the blood to circulate because of the roadblocks. You will have a hypermetabolic state. Initially, you'll have an increase in cortisol, so you'll have an increase in glucose as well as an increase in insulin resistance. But then eventually the liver will burn up all its glycogen and you'll start to have to burn fatty acids. And as the liver will continue to fail, we will have a hypoglycemia, and the liver will have an inability to produce plasma proteins to synthesize protein, and we will have a decrease in onconic pressure. All of those things will result in a relative hypovolemia, not enough blood circulating in the vascular space. There's blood in there. There's fluid in there. You can just hear that it's all leaked into the interstitial space. So I have a relative hypovolemia. That's the first we're hearing those words. So a word about SIRS. How do you get it? Well, the thing is that it can come from, we use the example of a crush injury. It can come post-burns. It can come post-surgical procedures. It can come from ischemia, pancreatitis, an MI, different types of infections. Gram-negative bacteria are often implicated as triggers. So end result is we don't really 100% know why someone would mount a systemic inflammatory response. We could have two people who have the exact same, who are the exact same age and have the exact same set of circumstances which cause this particular trigger, and one will have an uncomplicated crush injury and one will end up developing SIRS, and we don't really know why. So let's talk about the definition. So when we talk about SIRS, we talk about an uncontrolled systemic inflammatory response as a result of some sort of an insult. Signs and symptoms are very vague. They mimic and could be just about anything else. You need to have two or more of the following: a high or low temperature, a heart rate above 90, a respiratory rate above 20, white count that's high or low or greater than 10% immature bands. Well, this could be just about anything. So we need to talk about sepsis. Sepsis is the words that we hear more often. The difference between sepsis and SIRS. Sepsis is SIRS. It is exactly the same thing, except that sepsis has a documented or suspected infection. So in other words, SIRS, a crazy, wild, inflammatory response, not as a result of anything. Something triggered it, so it's remote from the problem. It's not just in the leg where the crush injury was. It's not just where the surgery was. So now we have a crazy inflammatory response happening all over the body, where we have the fluid leaking out of the vascular space into the interstitial space. We don't have enough circulating volume. The blood pressure is low. There's decreased cardiac output, poor perfusion. We are in a hypermetabolic state. Now, that is SIRS. Sepsis is SIRS plus a documented suspected infection. There are three different types of SIRS. We can say three different forms. An uncomplicated sepsis. That means that the patient has the systemic response and they have a documented or suspected infection. It becomes severe sepsis when sepsis is complicated by organ dysfunction. And you would know dysfunction because we've talked about that a lot. Like we would have decreased urinary output, maybe a bilirubin would be up, maybe there would be complications. You will see the skin being poorly perfused. There's confusion, restlessness, agitation. We can detect hypoperfusion with an elevated serum lactic acid, lactate level. So a lactate level greater than 4, indicating that they have lactic acidosis because they have converted from aerobic to anaerobic metabolism. Now I'm assuming, and if you don't remember, when we're talking about the difference between aerobic and anaerobic metabolism and why lactic acid levels are up, you can refer to your lecture on decreased cardiac output with the heart failure lecture, or if you're unclear, still you need to come see me. So then the last one would be a systolic pressure less than 90 or a diastolic pressure less than 40 or a mean arterial pressure less than 65. So we have uncomplicated, severe sepsis, so that is hypoperfusion and hypotension. And septic shock is sepsis-induced hypotension despite fluid resuscitation. So when we talk about the treatment options, we're going to be talking about how we treat severe sepsis, and we will be talking about fluids. And septic shock happens when we're giving fluids and the person still has hypotension. Signs and symptoms. All the things that you can talk about with SIRS, plus the presence of a documented or suspected infection, and you can have one of these things: chills, hypotension, decreased skin perfusion, decreased urinary output. So I'm going to have this headline here. It says, sepsis and SIRS lead to MODS. Okay, sepsis and SIRS we can kind of use interchangeably, and you will see them used interchangeably because we never really know if somebody has an infection with SIRS. So SIRS is sepsis without an infection, but we most often hear it referred to as sepsis. So sepsis and SIRS lead to MODS. MODS, multi-system organ dysfunction syndrome. MODS is the failure of two or more organ systems. Urinary output is down, kidneys are failing, bilirubin is up, liver is failing, lungs, poor perfusion, so the failure of two or more organ systems. That means that homeostasis cannot be maintained unless there is some sort of an intervention. We have severe hypotension, poor perfusion that will lead to multiple organ dysfunction. The goal is to stop sepsis and SIRS before we get to MODS. What's important here is there's no clear-cut time when we slip from uncomplicated sepsis to severe sepsis and into septic shock or MODS, multiple organ dysfunction syndrome. It's kind of a continuum, and you just kind of have to watch, and we hope your patient's trending in the right direction. This is just a quick summary. So we have the release of the cytokines and the histamine. We have direct damage to the endothelium with the pavementing and the sticky white blood cells and the platelet. We have hypermetabolic state. We have massive vasodilation. We have the increased permeability. We have the inactivation of the clotting cascade and all those platelets everywhere. This is what's causing havoc with sepsis, SIRS, and MODS. So, the activation of that inflammatory cascade results in hypotension, decreased cardiac output, and decreased tissue perfusion. We have all those microemboli, which are causing the maldistribution or the redistribution or the shunting of blood. Now let's take a look at how that looks in each one of the organ systems. Let's look at the lungs. Okay, the respiratory system. So there is going to be a lecture that is posted on ARDS, acute respiratory distress syndrome. So we're just going to look at this here, but there's a whole 30 minutes on what ARDS is. So essentially, these are the important parts. This is the one summary slide to summarize ARDS. I won't say more than another 15-20 seconds on this because you'll listen to the lecture, and this will just trigger your mind when you're going through this packet. We have blood clots that are forming in the capillaries. And the blood clots that are forming in the capillaries make it difficult for the blood to move through the pulmonary vasculature. In addition to that, we have protein-rich fluid leaking out of the capillaries in the pulmonary beds, and it's filling up the alveoli. In addition, something unique because ARDS is essentially sepsis or SIRS of the lungs. And so eventually, the thing that's unique in the lungs is that there is a surfactant dysfunction, which means that the lungs are susceptible to atelectasis. So the end result in the respiratory system is that we will end up with ARDS, and that's the number one complication of sepsis. I should have said also, number one complication of sepsis is ARDS. However, a full 10% of all people that die in an ICU are because they have sepsis. So sepsis is super, super severe and is a major problem. Okay, so let's look at the cardiovascular system. So we have massive vasodilation. And that massive vasodilation has all the fluid leaking into the surrounding tissues. So there's not enough blood in the vessels. So cardiac output is down. And if cardiac output is down, and we know we have catecholamines that are asking tachycardia, asking the heart to beat faster because that's a normal compensatory mechanism. So what do I have? I'm going to have the possibility of myocardial depression. So it's not getting enough oxygen. It's not getting enough nutrients. It may manifest itself as angina. Let's think about what happens when the neurological system is not getting the oxygen and nutrients that it needs. We will have a change in mental status as a result of that hypoxia. We've impaired perfusion in the brain. So confusion, restlessness, agitation. And we know this is often an early sign. That's a sign of poor perfusion. It's often an early indicator of MODS. Let's look at the renal system. So we have a decrease in circulating volume. So you know when there's a decrease in circulating volume, you will have that renin-angiotensin system kicking in, trying to cause vasoconstriction, trying to hold on to sodium and water, and that's good. We need that in this instance. It's perfectly normal homeostatic mechanism, but eventually we will have a decrease in urinary output. We'll have an elevated BUN and creatinine, certainly a decreased GFR. We will suffer from acute kidney injury because of the hypoperfusion. The problem also is lots of times when somebody's septic and we're trying to use different antibiotics to treat the underlying cause, the drugs are nephrotoxic. So we've got to be very, very careful there as well. Technical difficulty for me. Okay, GI system. Motility is decreased. Why is motility decreased? We know when there is hypoperfusion, one of the very first compensatory things that the body does is shunt blood from the GI tract. And so our patients, as a result of this decreased perfusion, may have decreased motility. And when there's decreased motility, the patient's at risk for a paralytic ileus. You might see that manifested as abdominal distension. Because there is a decrease in perfusion, there is a decrease in mucus production. When there's a decrease in mucus production, our patient is at risk for a GI bleed. In addition, there's something called bacterial translocation. And this would be is a potential for somebody who has SIRS and doesn't have a documented infection to develop sepsis. So bacterial translocation is because of the changes in permeability to the vessels. some of the normal flora in the GI tract is allowed to leak out of the GI tract and leak into the capillaries. And when it leaks into the capillaries, then we get a blood infection because of this GI translocation. So the organisms got into the portal circulation, and then they migrate out to the rest of the body. The integumentary system. The integumentary system, that's the skin, also one of the places that normal compensatory mechanisms early on as a defense mechanism are going to shunt blood from our skin. Here this lady has cyanosis, you see. She's got a bluish gray type of coloring on her hands and her nails. She's cool and clammy. She's got poor capillary refill. The patient will also be in a hypermetabolic state, as we talked about. Initially, there will be hyperglycemia because there is an increase in cortisol levels. There's an increase in catecholamines. So the cortisol is causing an insulin resistance. The increase in catecholamines is asking the liver to break down the glycogen which is increasing sugar levels, but eventually the liver will fail. Despite all attempts, we will eventually have a hypoglycemic effect. Because of the increased levels of cortisol, circulating cortisol, we will see the catabolic effects of that cortisol. We talked about liver dysfunction, and then certainly as the body enters into this hypoperfused state, not enough circulating oxygen, it's going to be burning, it's going to be doing anaerobic metabolism and releasing lactic acid, causing an acidic environment. The hematologic system. So in the hematologic system, we're going to talk about DIC in a minute, disseminated intravascular coagulation. But right now, let's talk about some electrolyte disturbances and why we might have some of those electrolyte disturbances. One, we said that the kidney's not getting enough oxygen, it's not getting enough perfusion, so it's going to kick in the renin-angiotensin-aldosterone system. It is going to have the kidney releasing angiotensin 2, holding on to as much aldosterone as possible, increasing aldosterone. So we're holding on to sodium and water, which is trying to help our poor circulating volume. But while we're holding on to sodium and water, we will be spilling potassium. In addition to that, the catecholamines are high. And when the catecholamines are high, we have a lot of circulating catecholamines. We have potassium that is moving back in to the cells. And so the potassium may be low. And we know that when the potassium is low, we are at risk for dysrhythmia and muscle weakness. In addition to that, we have the metabolic acidosis as a result of the increase in the lactate, as well as the increase in the ketones, because after the liver burns up all the glycogen, we start burning amino acids and fatty acids. Disseminated intravascular coagulation, DIC. DIC is a thrombohemorrhagic disorder. Let's think about this. Thrombo, lots of thrombuses, lots of blood clots, hemorrhagic. So we said that as a result of all the cytokines and the wild inflammatory response, we have all these blood clots all over the body. And normally blood clots are only stable for a specific period of time. And at the end of that specific period of time, the blood clot begins to break down. And that is normal. That's what happens. And when that blood clot breaks down, it makes FDP, fibrin degradation product. And that FDP is an anticoagulant. So if we have a little bit of a problem with our initial problem, we had a crush injury. And if the crush injury we have all these little blood clots in there. They begin to break down. That's good. Because if it was a localized response, the blood clot breaks down, releases FDP, and FDP is an anticoagulant. And that's good because we don't need any more. We've solved the problem. We don't need any more blood clots coming to this area so that FDP as an anticoagulant stops blood from clotting in that area. Well, when we have this massive, crazy response and there's blood clots everywhere, these blood clots start to break down. So there's lots of blood clots, so lots of platelets have been used up. So there's thrombocytopenia. And then we start to have all this anticoagulation in the bloodstream. Then it's difficult if we have some other sort of a problem. It's difficult to maintain clotting and the person is at risk for hemorrhage. So we have lots of blood clots and the person is at risk for hemorrhage. That is when we're talking about DIC. Okay, this is essentially what I just said to you. So I'm just going to skip this slide in interest of time. How do we treat DIC? We treat it with, first of all, we'll diagnose it by looking at a D-dimer. A D-dimer will tell us that there's blood clots as well as FDP. What do? We can consider using blood or blood products and heparin. And so, support them if they need platelets. Give heparin so that we don't make any more unnecessary blood clots. And if we don't make any more unnecessary blood clots, then the FDP will go lower. And also the main thing is to treat the underlying cause of the DIC. Get rid of the sepsis and it won't be there. Let's spend a couple minutes talking about the diagnostic studies for sepsis or SIRS. Okay, so we have to get blood cultures and we're checking for aerobic and anaerobic organisms. We need to have 2 sets drawn from 2 different spots. If a person has a vascular device, they have a subcutaneous port or a PICC line or something like that, one will come from there and one will come from a percutaneous location, the antecubital space or something. We need to culture everything. Culture the urine, any cerebrospinal fluid that might be leaking, any wounds, any respiratory secretions, anything that you could possibly culture, we want to culture. We're looking for infection. We need to do a chest x-ray. We want to make sure there's no pneumonia in there. We're looking for an H and H because a low hemoglobin means that there's poor tissue perfusion. And anything that we would be looking for, we're concerned about a hemoglobin less than 9, but we definitely are going to transfuse for 7, below 7. We're looking at a BMP. We're looking for hypokalemia. So slide number 27. Hypo-K. There will be the hyper and then hypoglycemia that we talked about. BUN and creatinine could be elevated. GFR will be down. Certainly we're going to be doing a CBC with differential. We're going to be looking at the platelets especially. Platelets will rise at the onset because they're rushing to the area to try and do the job that they're supposed to do. And then they're going to fall as the disorder progresses and they start to get used up. We're looking for leukocytosis. We're looking for elevated white blood count, azotemia, meaning signs and symptoms of nitrogenous wastes building up. We talked about the thrombocytopenia, anemia, certainly hypoxemia, all these different. So ABGs is something else that we're going to take a look at. So here we're talking about the coagulation studies for the DIC. Like I said, we're going to be looking at increases in PT, PTT, and then all of the different variations of the FDP tests. ABGs, looking for signs of lactic acidosis. There we go. A lactate greater than 4 is diagnostic for severe sepsis and septic shock. Septic shock, you know, is severe sepsis that is unresponsive to fluid resuscitation. And arterial base deficit, the amount of, base excess, the amount of base that they have to add in order to get the pH corrected, usually -2 to +2. But I don't need you to memorize that. Here's a slide about lactic acidosis because I felt like I just couldn't leave it. So normal serum lactate levels are 0.5 to 2.2. A critical value is greater than 4. If they have a lactate level greater than 4, they are at much greater risk for death. So the greater the lactic acid level, the increased risk for mortality. If a person gets MODS, the prognosis is poor. So our job is to prevent the progression of sepsis and SIRS to MODS. We need to do everything we can to prevent that. It is a matter of the nurse being hypervigilant when you have a patient that is at risk for developing sepsis or SIRS. You need to be hypervigilant. Often the first signs are very, very subtle. Something as slight as an increase in the heart rate is often the first sign. Slight increases in temperature, slight changes in mental status. It requires astute assessment skills for the nurse to get that identified early. And so when we're talking about identifying sepsis and SIRS early, timing is everything. And we're going to be talking about evidence-based practice. What we're going to talk about here today is based on the 2013 Surviving Sepsis Guidelines. ABGs are always the first thing that we want to do because we want to find out if there's poor tissue perfusion. And we need antibiotics on board within 45 minutes. It is ideal to have blood cultures done before antibiotics. That is a general rule of thumb for all nursing care everywhere. You culture before you give antibiotics. But the Surviving Sepsis Guidelines of 2013 say if there is some major reason, I can't imagine in one of today's hospitals, why you could not get blood cultures from 2 different spots within 45 minutes, you need to have those antibiotics rolling. It is that important. We need to obtain, like I said with the ABGs, we need to obtain a lactate level immediately to evaluate end organ hypoperfusion. Again, I'll repeat. A lactate level greater than 4 is highly suspicious for significant hypoperfusion and requires immediate fluid resuscitation. And then for all conditions. And then we are going to be talking about interventions to optimize oxygen delivery. So first we can start with a nasal cannula for patients who are conscious, spontaneously breathing, and have adequate gas exchange. But for patients who are unconscious or demonstrating some respiratory distress, intubation and mechanical ventilation are usually required. So I put here on your slide, first you go to nasal cannula, then you go to 100% non-rebreather, and then after the non-rebreather, if they still having difficulty, intubation and mechanical ventilation. A lot of times, it's not that they can't breathe, it's just that the work of breathing becomes so difficult and it takes up so much of their energy that we end up needing to support them. Just a word about oxygen. Remember that oxygen is crucial, but you have to have, proper oxygenation is crucial. But you have to have careful attention to oxygen concentration, because it's important to remember that oxygen is a drug and it can be toxic to the cells. That's why we're always trying to put the patient on the least amount of therapeutic oxygen as possible. They call that too much oxygen to the cells is called hyperoxia, and it's caused by the delivery of oxygen that's at a too high of a concentration, and it damages the tissues and causes the production of free radicals, which cause all kinds of problems. This slide talks about interventions to decrease oxygen consumption or O2 demand. So certainly oxygen consumption and O2 demand, mechanical ventilation will help with that, because it will decrease the work of breathing and allow the patient to not use as much energy. So we want to decrease the total and other ways to decrease oxygen demand is to decrease the total body work. Make sure you have reduced pain, reduced anxiety, and you are maintaining the person in a normothermia state. That will help to decrease oxygen demand. So anybody who has a fever gets acetaminophen. You are going to keep the lights out. You're going to minimize the number of visitors that are there. You're not going to have the radio and the TV on, people having a party. This is, you are trying to minimize the amount of oxygen that body needs while it is in that hypoperfused state. And like I said, the mechanical vent plays a really important part in decreasing oxygen consumption, because it minimizes respiratory muscles and the oxygen that they need, because it takes over the work of breathing. But that being said, if we're putting somebody on a vent to decrease the work of breathing, we may need to use neuromuscular blocking agents, because they can decrease oxygen consumption by decreasing voluntary muscle use. We like to use drugs such as Pavlon, but that will paralyze the muscles, and it's not recommended for any extended period of time. Neuromuscular blocking agents have been shown to increase the time to extubation in an ICU, but they contribute to muscle wasting. So we really have to be alert when we're using them. They're considered to be a high alert drug. It's recommended that they only be used in cases where conservative therapies, such as other things that will decrease oxygen demand, would be things like benzodiazepines, opioids. Propofol is great. That's what we see most often used now before we go to those neuromuscular blocking agents like the Pavlon. So let's have a word about sedation. IV propofol is the preferred method of sedation to decrease oxygen consumption, because it works really quickly to induce a very deep sedation, and it has a very short half-life. So when you're administering propofol, mental status must be evaluated daily, because the patient will not be arousable. So we wean them every 24 hours. You got to check. So you can take them off the medicine, and within a minute of discontinuation, the deep sedation quickly returns, and then you can check their level of consciousness and put them back to sleep. Let's see more about sedation. Ativan and Valium are used to control anxiety and to sedate, but they have a longer half-life. If prolonged sedation is necessary, Ativan is the drug of choice, but there's some evidence of a drug-induced delirium. Let's talk about other ways to decrease O2 consumption and oxygen demand. I wanted to just make sure they're on a slide here. Decreasing anxiety and pain, maintaining hemoglobin levels because that carries oxygen, working on the temperature, and certainly we need to maintain glucose levels. So when we're talking about pain and anxiety, that stimulates the SNS, which increases metabolic rate and oxygen consumption. So we'll use analgesics and other strategies to reduce pain, like opioids. Hyperthermia increases oxygen demand and metabolic requirements. So if somebody has a fever, I said give them acetaminophen, put a fan in the room, put them on a cooling blanket. Watch for shivering, because shivering increases metabolism and oxygen consumption also. So you can't take your patient from one extreme to the other. No shivering. And then the last thing on this slide is maintain glucose levels. So we have a stress-induced hyperglycemia initially, related to the increased sympathetic nervous system and the cortisol. So it's recommended to begin insulin dosing when 2 consecutive readings are greater than 180. And then we need to maintain the dose between 140 and 180. Or not maintain the dose, maintain the blood sugar between 140 and 180. We don't want the sugar less than 110. 140 to 180, we rather them be a little high because we don't want them to burn ketones. But we certainly do not want the sugar less than 110 because of the risk for hypoglycemia. And then just the last word about the hemoglobin levels. We need to maximize oxygen delivery. If they have a hemoglobin less than 7, we'll transfuse them with some packed red cells. And our target for adults is to keep that hemoglobin between 7 and 9. Maintaining fluid resuscitation, maintaining fluid circulation. Okay, so we said these people have massive relative hypovolemia, so we've got to do something to correct this fluid, to correct this circulation problem. We've already said for all our people with sepsis, within the first 45 minutes, we have started them on antibiotics. We've checked their ABGs. We've gotten blood cultures. Now for poor perfusion, now we are going to do fluid resuscitation for those people. And we are going to use crystalloids, things like albumin for patients who need a lot of fluids. So we're going to aggressively treat the hypoperfusion, the poor circulating volume, with fluids as much as 0.5 mLs per kilogram per hour. So lots and lots of fluid. We're going to be very aggressive. If the fluids don't work, we're going to use vasopressors. We want to keep somebody's mean arterial pressure greater than 65. So some of the vasopressors would be I got interrupted, so I'm going to hopefully be able to pick up. We're talking about vasopressors and maintaining a mean arterial pressure greater than 65. So one of the main vasopressors is epinephrine, vasopressin, and the job there is a vasopressor, is to press, is to vasoconstrict. And we'll remember that always give fluids first, pressor second, or at least at the same time. Because if you need to have fluid on board, because if you don't have fluid in those vessels, there's nothing to press. So you're not going to be as effective. So fluids first, followed by the pressors. Then we could also enter in there ionotropic therapy, like dobutamine. That's used when there's ongoing signs of hypoperfusion despite maintaining adequate intravascular volume and adequate MAP. So then they would enter in there the dobutamine, the ionotropic. So first the antibiotics went in the first 45 minutes and kind of all at the same time in real life. then fluids to at 0.5 per kilogram per hour, as high as that, followed by pressors, followed by ionotropic agents. So adjunct therapies, we can talk about corticosteroids. They're not used if fluid resuscitation and vasopressors are able to achieve a hemodynamically stable patient. And so if they are used, we need to taper them once the pressors are not needed anymore. Corticosteroids are used to treat septic shock when hypotension persists despite fluid resuscitation. The idea is that they decrease the inflammatory response, so they should decrease the amount of circulating cytokines. In the absence of shock, we would try to not have to use corticosteroids. DVT prevention, VTE, venous thromboemboli. So we would be looking at things like Lovenox daily, sequentials or intermittent pneumatic compression stockings. We are always considering stress ulcer prophylaxis. So histamine blockers or PPIs. We want to start to feed them. We prefer enteral feedings versus parenteral. So oral or enteral feedings are really important. We want to start them as soon as we can. We can start them low dose feedings and then advance them as tolerated. And then continuous renal replacement therapy. We talked about that a little bit when we did renal failure, and that is essentially for failing kidneys. We will be having them on continuous dialysis. A couple other things that I wanted to mention before we evaluate the effectiveness of our care is remember that you should be ready to be rapidly changing IV bags and paying careful attention to the rate and type of the fluids. I&O becomes essential. You need to watch when we have fluids going in that quickly. You need to watch for overhydration, manage the IV site. And then one of the most important things that you can do, these people are super, super sick. So vigilant communication with family and realistic treatment goals and likely outcomes. Really need to be honest with the patient's family. And it is a very, very stressful time for everyone. Okay, and now finally, evaluating the effectiveness of our care, we are looking to see, do we have a mean arterial pressure greater than 65? Is the lactic acid better? Is it improved? Is the skin warm and dry? Is the urine output greater than 30? Is the BUN and creatinine getting back in line? Is blood pressure and O2 sat improving? Have they returned to the baseline of their mental status? These are all things that we can do to evaluate the effectiveness of our care. Before I leave you, I just went over my notes to make sure I told you everything. When we were talking about nutritional support here, we said that they should have enteral feedings or oral feedings as early as we can. Start them slow. We want to make sure also, I said it before, but I want to make sure you remember now, that we have tight glycemic control. Ideally, we would be between 140 and 180, less than 180, greater than 140, but certainly never any less than 110. Better outcomes between 140 and 180 have been reported. So we'll typically hang insulin and dextrose, and we want to make sure that we are watching them with those enteral feedings to make sure that we prevent protein calorie malnutrition. Otherwise, they won't be synthesizing, the liver won't be able to synthesize protein, and we won't have enough albumin to hold the fluid in the vascular space. Thank you so much for your time and attention. I'll answer any questions that you have. We'll review this in class in the next week or so, and I'm happy to answer any questions. Again, I truly appreciate your time. I hope this was beneficial.